The Ethical Perils of Medical Assistance in Dying from Mental Illness, a Critique of Coercion and Flawed Assumptions. The proposition that medical assistance in dying, MAiD, is an ethical solution for individuals suffering from mental illness is deeply flawed, rooted in questionable psychiatric practices and systemic failures that undermine patient autonomy and informed consent. By examining the coercive nature of psychiatric treatment, the lack of scientific rigor in diagnosing mental disorders, and the parallels to historical pseudoscience, we can see why offering MAiD for mental illness is not only premature but also morally indefensible. The absence of evidence that candidates for MAiD have explored non-pharmacological recovery paths further compounds these concerns, highlighting the need for a critical reevaluation of this practice. Historical echoes of eugenics. The notion that mental illnesses stem from genetic deficiencies, which underpins much of modern psychiatry, bears an unsettling resemblance to the discredited genetic purity theories of Nazi Germany's T4 program. In the 1930s, this initiative, cloaked as mercy death, justified euthanizing individuals deemed genetically undesirable based on traits beyond their control. Post-World War II, such pseudoscience was thoroughly debunked, yet contemporary psychiatric discourse often echoes these flawed assumptions by framing mental disorders as inherent lifelong conditions requiring medical intervention. While modern practices claim to prioritize informed and consensual decisions, the reality is far more troubling, as patients are frequently coerced into accepting diagnoses and treatments that may not serve their best interests. Coercion and the illusion of informed consent. The psychiatric system often pressures patients to accept diagnoses like schizoaffective disorder or bipolar disorder, creating a self-fulfilling prophecy. Although individuals theoretically retain the right to reject such labels, the system is structured to undermine autonomy, insisting that acceptance is non-negotiable. Patients are encouraged to rely on those closest to them, often the very sources of their distress, as their support network. Potent psychotropic medications, sometimes administered involuntarily, further complicate this dynamic. When patients attempt to discontinue these drugs, severe withdrawal symptoms can exacerbate their condition, often surpassing the initial distress. Alarmingly, the system frequently misattributes these withdrawal effects as evidence of a genetic condition relapse, using them to justify lifelong medication. This practice nullifies the patient's informed decision to stop treatment, effectively dismantling the concept of consent. The cognitive decline induced by these medications can distort perception, overriding survival instincts and convincing patients to accept a false narrative about their condition. This coercion is exacerbated by laws allowing release from psychiatric wards contingent on medication compliance. Such policies exploit the human desire for freedom, creating a cycle of court-ordered treatment that fosters phenomena like Stockholm Syndrome. Patients conditioned to seek social approval may convince themselves that treatment is necessary, a belief reinforced by loved ones who may also be influenced by psychotropic medications like SSRIs. This dynamic can lead patients to prioritize social acceptance over their own well-being, complying with medication to avoid institutionalization rather than through genuine choice. Misdiagnosis and iatrogenic harm. Many mental health diagnoses do not arise spontaneously but are often conflated due to overlapping symptoms. For example, bipolar disorder is frequently misdiagnosed as ADHD, leading to contradictory treatments. ADHD is treated with dopamine-enhancing drugs, while bipolar disorder is managed with dopamine suppressants. This discrepancy suggests that medications themselves may precipitate psychiatric symptoms. In this vulnerable state, patients' memories become skewed, amplifying the emotional significance of past events. They may apologize for actions previously deemed inconsequential, ascribing undue weight to distant memories. Clinicians can exploit this altered state to convince patients they have always had a condition, despite evidence to the contrary. The absence of rigorous long-term studies, such as a decades-long comparison of 100 medicated versus 100 unmedicated individuals with bipolar disorder, undermines claims of lifelong conditions. A notable schizophrenia study by Harrow and Job, 2012, found that non-medicated patients had significantly better outcomes over 15 years, with 40% achieving recovery compared to 5% of medicated patients, suggesting that medication may hinder rather than help long-term recovery. Systemic failures in education and healthcare. The over-reliance on medication reflects broader systemic failures, particularly in education and healthcare. In education, children labeled as bored or disruptive are often medicated with amphetamines like Adderall to enforce compliance with outdated curricula. Adderall does not enhance intelligence. Rather, it impairs the interaction between the brain's critical thinking faculties and its reward system. In educational settings, when a curriculum includes subjects that a child perceives as obsolete due to technological advancements, the critical thinking region of the brain fails to activate the reward system for mastering those tasks. For instance, in a pre-calculator era, learning complex mathematics was intellectually stimulating, as it was perceived as a gateway to numerous opportunities, thus engaging the reward system. However, in a post-calculator world, a child aware of this technology recognizes that mastering basic arithmetic is less critical, as calculators enhance efficiency and enable more sophisticated computations. The brain's reward system prioritizes leveraging the tool over traditional learning. This will make the child want to take on more advanced challenges, such as how to make the most of this new tool. Giving Adderall to a child in this approach does not enhance intelligence, but disrupts the interplay between critical thinking and the brain's reward system. Administering Adderall artificially stimulates the reward system, fostering compliance with obsolete tasks rather than preparing students for a future shaped by artificial intelligence. The education system's failure to adapt to technological advancements mirrors psychiatry's reliance on medication over addressing environmental stressors or fostering resilience. Consider this perspective. When instructing aspiring chefs in the culinary arts, it would be inefficient to dedicate the initial 4 months to teaching them how to build a fire from scratch without the aid of stoves, lighters, or grills by gathering fresh timber, drying it, and crafting an axe from natural materials to fell the tree. While such primitive skills hold value in specific contexts, they are largely irrelevant if the objective is to cultivate mastery in modern cooking. Numerous tools exist to circumvent this rudimentary step, enabling a focus on advanced techniques. Yet the current educational system often fails to recognize this paradigm shift, neglecting to adapt its methods to the realities of a world transformed by pre- and post-computer technological advancements. One aspect often overlooked is the hypothetical scenario in which individuals who struggled with traditional curricula, perhaps due to a lack of motivation or inherent disinterest, were to use amphetamines to enhance their focus. Suppose these individuals successfully completed advanced degrees, such as a master's in architecture or another field requiring sophisticated mathematical skills. You can claim the medication was a success story. However, in reality, how might they fare in today's job market? To be candid, their prospects may not be as promising as one might assume. Artificial intelligence has already surpassed human capabilities in many of these domains. In retrospect, their inclination to play on the computer during high school might have been a more prescient choice than pursuing skills that machines can now outperform with ease. It's almost as though their subconscious recognized this technological trajectory, manifesting as a lack of motivation to engage with such subjects. Consider this analogy. If I were to enter a room where adults in their mid-30s were coloring in a coloring book for children and claimed that these skills would lead to millionaire status, how would I respond? Naturally, I would dismiss the notion as absurd. The only conceivable way to convince me otherwise would be if I were under the influence of street drugs such as methamphetamines, which could impair my critical thinking and make me susceptible to believing outlandish ideas. This parallels how impressionable children might accept certain teachings, such as the biological impossibility of men becoming women, if presented authoritatively. Those with a more skeptical disposition might lose respect for the curriculum and disengage entirely. However, if these same students were given amphetamines, their critical faculties might become detached from their dopamine reward systems. In such a state, dopamine release is no longer tied to discerning truth, making them more likely to accept falsehoods without scrutiny. In healthcare, the shift from intellectual rigor to financial incentives has degraded the quality of medical practice. 50 years ago, medicine attracted critical thinkers driven by the challenge of devising life-saving treatments. Today, the system prioritizes profit, perpetuating treatments that may exacerbate illness. Intellectually astute individuals often recognize that many health issues stem from lifestyle factors or require straightforward solutions, yet the medical education framework rewards compliance over inquiry. This results in a cohort of younger physicians who may lack the capacity to question established protocols, endorsing harmful treatments without achieving long-term benefits. What research has explored the interplay of mental health diagnosis among socially connected individuals, particularly the potential for complementary or reciprocal relationships between conditions. For instance, if an individual is diagnosed with and treated for anxiety, what is the likelihood that their spouse or close associate is subsequently diagnosed with a condition such as bipolar disorder? In educational settings, to what extent might a teacher's impaired judgment, potentially influenced by their own mental health treatment, hinder their ability to engage students effectively or discern the causes of students' inattention, possibly due to a fixation on external or artificial factors? Is the teacher also so impaired they may be facilitating bullying and be completely unaware of it? By singling out students teaching the other children, they need to pity that student because they don't have the potential as other students to be successful. The teacher thinks they're doing good but really causing hostility. What peer-reviewed studies have investigated the correlation between an individual's use of psychotropic medications and the likelihood of mental health diagnosis among those in their immediate social or household environment? Are there data-driven studies on this topic, and if so, who funds such research? For example, if a household member is prescribed anti-anxiety medications, such as benzodiazepines, what is the probability that another individual in the same household is diagnosed with a condition like bipolar disorder? Could these medications induce heightened sensitivity or paranoia, causing the medicated individual to misinterpret another's behavior as indicative of a mood disorder, thereby prompting them to encourage mental health evaluation? Without rigorous peer-reviewed studies or statistical evidence, such hypotheses cannot be dismissed outright. They require empirical investigation to be substantiated or refuted. Furthermore, are there studies examining whether teachers using psychotropic or hormonal medications influence the likelihood of their students receiving mental health diagnosis? What statistical correlations, if any, exist, and have such studies been conducted? Over time, it has become increasingly apparent that some adults struggle to accurately assess others' intelligence or capabilities. In today's polarized political climate, for instance, individuals may hastily dismiss the intellectual capacity of a billionaire, equating it to that of a child, without acknowledging the strategic acumen required to amass such wealth. This suggests a potential cognitive or perceptual impairment. Anecdotally, I have observed that individuals who misinterpret my words, actions, or body language, often attributing them to mild paranoia, are frequently prescribed selective serotonin reuptake inhibitors, SSRIs. Are there studies investigating whether SSRI use correlates with misjudgments of others' intentions or cognitive abilities? From an evolutionary perspective, anxiety likely served as a survival mechanism, heightening vigilance to environmental threats. However, when anxiety is medically suppressed, compensatory mechanisms, such as hypervigilance, may emerge. This could manifest as an overanalysis of conversations, locations, or others' facial expressions to detect perceived threats. For example, an individual on anti-anxiety medication might observe someone entering a store, deliberating over whether to take a cart or a basket, and misinterpret this as confusion, prompting an offer of assistance. "Are you looking for something? Can I help you?" While seemingly benign, this reflects a failure to contextualize the situation, akin to the unease triggered if someone were rummaging through personal belongings in one's home, eliciting a similar response, "Can I help you with something?" Similarly, if someone casually remarks, "That person at the door was rude," an individual on anti-anxiety medication might fixate on this comment, initiating an intense conversation to downplay its significance, assuming the speaker is deeply distressed. In reality, the speaker may have already dismissed the incident as trivial, perhaps thinking to themselves, "That person was rude, but it's not a big deal, and I'll move on." The medicated individual's overanalysis, potentially driven by paranoia or a belief that they can discern others' thoughts, may amplify the situation while simultaneously attempting to minimize it, causing irritation to the initial speaker. This may lead them to reassess what they say in front of the medicated individual to avoid such interactions in the future. The core issue is that the person on medication may overanalyze the mental state of the speaker, assuming they are panicking and thinking, "My life is over because this person was rude to me. I'll lose sleep, my job, everything because I'm so fragile that rudeness will destroy me." In reality, the speaker is not panicking, and any vocal tremor might simply stem from being out of breath from walking. Such hypervigilance, potentially induced by medication, may be mistaken for an emergent severe condition, such as schizoaffective disorder, with clinicians suggesting the initial anxiety diagnosis was a misidentification of a latent condition. However, there is no conclusive evidence that such conditions would manifest absent the initial treatment. The reliance on medications like Adderall or anti-anxiety drugs, often deeply integrated into a patient's sense of self, due to perceived benefits, may precipitate a cascade of further diagnoses and treatments. This raises concerns about whether the medical establishment adequately evaluates the necessity of initial treatments or acknowledges their potential role in triggering subsequent conditions. The medical community often asserts that medications do not cause severe mental health conditions but may trigger latent ones, a position that appears logically inconsistent. If a condition only manifests post-medication, the claim that it was always present is questionable, suggesting the condition may be contingent on the drug's influence, yet clinicians rarely recommend discontinuing the original medication, instead attributing progression to an inevitable underlying illness. This overlooks the possibility that conditions like ADHD or anxiety may not be fixed disorders but dynamic survival mechanisms shaped by environmental and social context. For example, children are often taught to cope with challenging environments, such as bullying in schools, rather than being encouraged to escape them. Conversely, adults are advised to leave toxic workplaces to find healthier environments, yet medicating children to tolerate adverse settings is widely accepted. This inconsistency extends to adulthood, where dissatisfaction with jobs or social circles is frequently addressed with medication rather than systemic change. This raises critical questions about whether the medical establishment's reliance on pharmacological solutions undermines adaptive responses to environmental challenges. Reflecting on personal experience, I discontinued pharmaceutical interventions a decade ago after realizing that ADHD medications were not only exacerbating my difficulties but were likely their primary cause. The skills I developed during unmedicated periods, when labeled a poor student, proved far more valuable to my career and financial success than the knowledge acquired under medication's influence. This underscores a critical point. The issue lies not with the individual, but with systems that prioritize compliance over potential, resorting to medication to dull cognitive faculties, rather than fostering adaptability. In traditional medical research, placebo-controlled studies are designed with a clear purpose. Belief influences behavior. When individuals believe they are receiving treatment, their actions often align with that belief. To mitigate this, studies are structured so participants are unaware of whether they are receiving the active treatment or a placebo. However, claiming mental illness is real in a person cannot be reliably studied if subjects are aware of their diagnosis, as their belief in the condition may bias their behavior and skew results. A rigorous study would need to account for this bias by withholding the diagnosis from participants, which is ethically and practically challenging. This issue underscores a critical flaw in programs like medical assistance in dying, MAiD. When individuals are told they have a mental health condition with no potential for recovery, as determined by a mental health expert, they may internalize a diminished sense of self-worth. Such pronouncements, often made by professionals with limited personal knowledge of the individual, are based on the biased framework of prescribed medical treatments. This dynamic can lead individuals to feel their lives are not worth living, prompting them to consider MAiD. The reliance on external judgments, rather than fostering personal agency, raises profound ethical concerns about the validity and impact of such programs. The fatal flaw of MAiD for mental illness. The application of MAiD to mental illness is particularly troubling given these systemic issues. Candidates for MAiD often claim to have tried every treatment, yet there is no evidence that they have successfully withdrawn from all medications and remained free of potent substances for 5 or more years. Without exploring this path, it is premature to conclude that their condition is untreatable. The psychiatric system's failure to prioritize non-pharmacological interventions such as psychosocial support or lifestyle changes, and its tendency to misdiagnose or induce symptoms through medication, casts serious doubt on the ethics of offering MAiD. Approving euthanasia for mental illness risks endorsing a system that may have created or exacerbated the very suffering it claims to alleviate without exhausting all avenues for recovery. Conclusion: a call for ethical reform. Medical assistance in dying for mental illness is ethically untenable due to the coercive nature of psychiatric treatment, the risk of misdiagnosis, and the lack of evidence supporting lifelong diagnosis. The main points of this critique are historical parallels. The assumption of genetic deficiencies in mental illness echoes debunked eugenics theories, raising concerns about the scientific validity of current psychiatric practices. Coercive practices. The psychiatric system undermines autonomy by pressuring patients to accept diagnosis and medications, misattributing withdrawal symptoms as relapse and exploiting the desire for freedom, negating informed consent, misdiagnosis and iatrogenic harm. Overlapping symptoms lead to frequent misdiagnosis, and medications may worsen conditions, with no long-term studies validating lifelong diagnosis. Systemic failures. Education and healthcare systems prioritize compliance over innovation, medicating individuals to enforce conformity rather than addressing environmental or societal factors. Unexplored alternatives for MAiD candidates. The absence of evidence that MAiD candidates have pursued medication-free recovery for extended periods undermines claims of untreatable conditions. To uphold ethical standards, we must prioritize patient autonomy, invest in rigorous longitudinal research, and explore non-pharmacological interventions before considering MAiD for mental illness. Offering euthanasia without addressing these systemic flaws risks perpetuating harm under the guise of compassion, betraying the principles of medical ethics.